Okay, it is 2 minutes after, so we will go ahead and get started. My name is Megan Kaler. I am the facilitator and primary moderator for today's Pharmacy Section Journal Club. Today we have two presenters. We have Sama Hamad and Andy Jadis, who will be presenting two separate articles. While they are presenting, if you have questions, please feel free to post them in the chat, and then I will go through the questions at the end of each presenter's presentation, and then we will go into the next article. So with that, I'm going to stop sharing my screen, and Sama, you can go ahead and share your slides and go ahead and get started. Okay, and I can see your slides.
Thank you for that introduction. Welcome, everyone. My name is Sama Hamad. I'm a PGY2 critical care pharmacy resident at Ochsner Health in New Orleans, Louisiana. And today I'm going to talk to you about the article that I chose, Association of Chloride-Rich Fluids and Medication Diluents on the Incidence of Hyperchloremia and Clinical Consequences in Aneurysmal Subarachnoid Hemorrhage. A bit of background, as we know, the subarachnoid hemorrhage is caused by a ruptured aneurysm, and it is considered a neurological emergency. Just to recap, we can expect these different complications following an aneurysmal rupture. We have the acute phase, which is within the first 24 hours. Then we can see early brain injury within the first 72 hours, where we expect to see inflammation, seizures, cerebral edema. And then finally, up to 14 days, we can see delayed cerebral ischemia, or DCI. And this is when vasospasm, microvascular collapse, and infarction typically occur. With that being said, we know that there is a high mortality and morbidity associated with aneurysmal subarachnoid hemorrhage due to those several complications that I just mentioned: vasospasm, hydrocephalus even, DCI, and rebleeding. Therefore, management strategies typically include therapies that prevent vasospasm and reduce intracranial pressure. What used to be known as Triple H therapy, which was hypertension, hemodilution, and hypervolemia, was used to maintain adequate cerebral perfusion. However, over the past few years, complications of this therapy have caused it to fall out of favor. These complications include pulmonary edema, myocardial infarction or cardiac ischemia, hyponatremia, which could even further worsen cerebral edema. Now, hyperosmolar therapy is one component of management of aneurysmal subarachnoid hemorrhage, and specifically it's the cornerstone of cerebral edema management. This occurs in about a third of our patients, and the goal here is to reduce that intracranial pressure and improve cerebral blood flow. When focusing in on the management of patients with aneurysmal subarachnoid hemorrhage and fluid, there are a couple points to consider: the ideal fluid type, which is kind of unknown, the different and hidden sources of fluid intake, and the potential for chloride-rich fluid administration. Hyperchloremia here is considered a serum chloride level of greater than 110. However, you might see it in other sources of greater than 109. And this has the potential to cause renal vasoconstriction and subsequently a reduction in renal blood flow. And this has been reported to correlate with AKI, acid-base disturbances, and mortality. There's been a growing body of literature honing in on the effects of hyperchloremia and renal function in AKI, and we have had several landmark trials come out within the literature in the past few years pointing that out. The SALT-ED trial in 2018 looked at normal saline versus balanced crystalloids in a single-center trial in 13,000 non-critically ill patients in the emergency department. When looking at the primary outcome of hospital-free days, this didn't differ between the two groups. However, investigators found lower major adverse kidney events in the patients who received balanced crystalloids compared to normal saline. And then the same year, with the same investigators, was published the SMART trial. The SMART trial was very similar, but investigators here looked at 15,000 patients across 5 ICUs. Again, here there were lower major adverse kidney events at 30 days with the balanced crystalloids group. And of note, the highest plasma chloride concentrations were reported here, and it was 108 for the balanced crystalloids group and 109 for normal saline. It is important to note that both of these trials were single-centered and reported composite endpoints where they kind of merged these renal and non-renal outcomes. However, these are kind of the reason why we think of chloride load in the first place, because we didn't really used to before. So these brought to our attention the potential impact of chloride on our patient outcomes. Aside from those, we have a few trials that specifically address chloride levels. First, we have this retrospective cohort study performed at an academic medical center, ICU, in nearly 2,000 patients with severe sepsis or septic shock. Investigators here assessed these patients with shock in their chloride levels, and nearly 1/3 of these patients had hyperchloremia at admission, here defined as chloride level greater than 110. Investigators found that every 5 milliequivalent per liter increase in chloride at 72 hours was independently associated with hospital mortality. Of note, those patients with hyperchloremia did have higher Apache 2 scores, SOFA scores, and need for mechanical ventilation at baseline. Then the acetate trial was published in 2020, and this looked at bolus doses of 23.4% sodium chloride versus bolus doses of buffered sodium chloride, sodium acetate in patients with aneurysmal subarachnoid hemorrhage and evolving hyperchloremia. This was kind of the first study to prospectively look at the relationship between hypertonic sodium chloride content and its effect on serum electrolytes and renal function in patients with aneurysmal subarachnoid hemorrhage. Investigators found a lower chloride load and incidence of AKI in patients who received that mixed buffered solution. However, this trial was underpowered due to a small sample size of 59 patients. Finally, here we have this most recent single-centered retrospective study from 2022 that looks specifically at patients with severe traumatic brain injury who had received hypertonic saline. Investigators found that specifically the duration of hyperchloremia and GFR at admission were associated with the development of AKI. However, again, it's important to note that this was a retrospective study of 123 patients. That brings me to the study looking at the incidence of hyperchloremia in patients with aneurysmal subarachnoid hemorrhage, factoring in the contribution of fluids, medication dilutants, and other fluid sources to chloride administration. This was a retrospective single-centered cohort study in patients with aneurysmal subarachnoid hemorrhage admitted to the neuro ICU in a 4-year time span of between 2015 and 2019. And investigators here included adult patients with aneurysmal subarachnoid hemorrhage who had been admitted for greater than 48 hours and received oral nimodipine. Patients excluded were those with traumatic subarachnoid hemorrhage, those who were pregnant, incarcerated, had AKI or CKD requiring renal replacement therapy at admission, moribund, or had early withdrawal of care. The primary endpoint here was looking at incidence of hyperchloremia, defined in this study as a chloride level greater than 109. Secondary endpoints included incidence of severe hyperchloremia greater than 115, incidence of AKI, need for renal replacement therapy, characterization of the source of fluid intake as well as chloride intake, length of ICU stay, length of hospital stay, and hospital mortality. The statistical analysis included student t-tests and Mann-Whitney U-tests for continuous variables, Pearson chi-square and Fisher's exact for categorical variables, and then a multivariable regression was performed to model the primary outcome of hyperchloremia and secondary outcome of AKI. In total, 234 patients with aneurysmal subarachnoid hemorrhage were admitted into this ICU and met inclusion criteria. Investigators presented the baseline demographics in such a way that divided these patients who met hyperchloremia, that primary outcome, versus those who had no hyperchloremia, which 75% did meet that primary outcome of hyperchloremia. Overall, the patients were similar between both groups, with the exception of the hyperchloremia group having a greater amount of females, and then the hyperchloremia group had a higher SOFA score. The Hunt-Hess score for both groups was 2, and the modified Fisher grade was 3. Those are 2 assessment scales that we use when managing patients with subarachnoid hemorrhage. The Hunt-Hess scale predicts the outcome and the risk of neurologic complications after aneurysmal subarachnoid hemorrhage. And this helps surgeons determine the surgical risk and timing of any interventions if necessary. It's an ordinal scale from 1 to 5, and it's based on important clinical signs and symptoms that patients present with, looking at level of consciousness and focal neurologic deficits. It ranges from grade 1, so asymptomatic or a mild headache, all the way to grade 5, which is when a patient presents as comatose. The higher the score, the higher likelihood of a poor outcome. This Hunt-Hess scale is widely known in the neural world and is often used in the literature. On the other hand, the modified Fisher scale was designed to predict cerebral vasospasm after subarachnoid hemorrhage based on the amount and pattern of blood visualized on CT at presentation. So patients with no hemorrhage or little hemorrhage versus a thick amount of blood, and this predicts the risk of vasospasm. Grade 1 correlates with like about less than 20% risk of vasospasm, whereas grade 4 is about 40% risk. These are some additional baseline characteristics that investigators presented, and these values are at admission. So of note, we can see that the hyperchloremia group had more patients with a higher GCS, with a lower GCS, and then slightly higher chloride levels at admission. However, you can see that there was similar renal function and sodium levels at baseline. When assessing outcomes, again, 175 patients met that primary outcome of hyperchloremia. Throughout the study duration, which was up to 14 days of ICU stay or ICU discharge, patients in the hyperchloremia group had a higher maximum chloride level, which was 115 versus 108 in the no hyperchloremia group. These patients also experienced a greater incidence of severe hyperchloremia, hypernatremia, and severe hypernatremia. The incidence of AKI was numerically higher in patients who developed hyperchloremia. However, this was not statistically significant. Of note, no patients developed a stage 3 AKI or need for renal replacement therapy. Patients in the hyperchloremia group had a higher cumulative fluid intake over the 14 days, which kind of makes sense considering there were more patients in the hyperchloremia group. So it made more sense that they would have a higher fluid intake. And finally, the chloride exposure and chloride dose over the first few days was similar between both groups. Here we have the median daily chloride trend over the 14-day study period, looking at serum chloride on the y-axis. The patients who developed hyperchloremia are in green. The patients who did not develop hyperchloremia are in blue. Also, AKI is in yellow, and no AKI is that darker green color. As we can see here, the chloride concentrations reached a max mean concentration by day 4 in patients with hyperchloremia, and it was about day 2 in those no hyperchloremia patients. And this was kind of consistently seen throughout those 14 days of admission. And again, those rates of AKI were similar between both groups. And this is how I looked at day 14. When looking at the multivariable logistic regression model for hyperchloremia, it was accounting for subarachnoid hemorrhage severity, age, and chloride dose within the first 48 hours. Sex, higher admission at SOFA score, cumulative fluid intake, and serum chloride concentration, as well as daily mean dose were independently predictive of hyperchloremia. Of note, male sex and daily chloride dose were actually inversely associated with the development of hyperchloremia. And there was also another multivariable regression model that looked at AKI and found that patients with CKD, sepsis, and nephrotoxin exposure were all independently predictive of AKI as well. This graph shows daily fluid intake in green, daily fluid balance in blue, and mean sodium chloride in yellow. We have the volume of fluid on the left-hand side and the chloride concentration on the right-hand side, and this is all plotted across the 14 days. As we can see, serum chloride mirrored daily fluid intake and overall daily fluid balance throughout the first 14 days of admission. Overall, investigators reported that a mean daily fluid intake of 3.7 liters was seen in the first 7 days, and then it was down to 3.6 liters from days 8 to 14. It is important to note that all patients were pretty euvolemic, and if you remember in our hyperchloremia group, they received more fluid. However, it kind of didn't really matter that much since we see they were all pretty euvolemic here, so they were putting out that fluid that they were receiving. Investigators here also did a great job of collecting exactly where all of this fluid and chloride came from. Graph A shows the average total volume of fluid administration per day, stratified by source over the 14-day period, and graph B shows the total chloride dose per day, stratified by source over the 14-day study period. Over the course of the study period, the majority of fluid intake was from enteral nutrition, followed by maintenance IV fluids and titrated IV infusions. The majority of chloride administered primarily came from maintenance IV fluids. And after this, it was enteral sodium supplementation and nutrition. The mean sodium dose per day was about 636 milliequivalents, and the mean chloride dose per day was 646 milliequivalents. Finally, the development of hyperchloremia was associated with a prolonged ICU length of stay, a longer duration of mechanical ventilation, a longer hospital length of stay, and a higher rate of hospital mortality than the patients who did not have hyperchloremia. The authors here concluded that hyperchloremia occurs at a high frequency in aneurysmal subarachnoid hemorrhage and is associated with poor patient outcomes. Maintenance IV fluids accounted for the highest proportion of cumulative chloride burden. For my critique and kind of relevance to practice, my first critique was this was a study of retrospective design and small sample size. I appreciated that nimodipine administration was reported. It was part of that inclusion criteria, so it was standardized in that sense. However, other management was not reported. I didn't know if aneurysms were stabilized. I didn't know if any coagulopathy management was done, any fibrolytics, any prevention, other methods of prevention of vasospasm treatment, how many patients went to IR. I didn't really know any of that. However, investigators again did an awesome job reporting that fluid, chloride, and sodium intake from all different sources that our patients can get it from in the ICU. And I think that makes us very conscious of where our patients can get it from. I just didn't know kind of the methods of administration and fluid choices per se. Again, of note, patients were pretty euvolemic throughout the 14 days throughout the study. And then a higher AKI was observed in the hyperchloremia group, not statistically significant. However, it was mainly just stage 1 AKI with no patients needing renal replacement therapy or stage 3 AKI. There was no assessment of vasospasm, cerebral edema, or DCI. I kind of, again, didn't know how sick these patients were in that sense, and then the management and treatment of that. So for me, it was pretty difficult to attribute that prolonged ICU length of stay, hospital length of stay, duration of mechanical ventilation, and mortality to those maximum chloride levels of 115 in that hyperchloremia group. It was hard for me to associate that, or was it just like those patients were sicker? Final takeaway, hyperosmolar therapies are employed in the management of aneurysmal subarachnoid hemorrhage, and they will likely include a high chloride burden. Hyperchloremia in this study was at an average max of 115, and this was not statistically significant, was not associated with a statistically significant increased risk of AKI. However, it is important to assess the sources of chloride intake, maintenance IV fluids, IV bolus, continuous IV fluids, and even enteral nutrition. I think this is definitely something that we as pharmacists are already doing in our daily workflow, but it's very much a nice reminder that fluid comes from all sources. And it's important to mitigate that chloride load, especially in patients with that worsening or wearied renal function. Thank you, guys. I will take any comments or questions at this time. I can see you.
Hey there. Okay, I will wait for questions to come through in the chat. In the meantime, I do have a question or two for you to get started. At your institution, do patients with aneurysmal subarachnoid hemorrhage receive continuous IV fluids as like a standardized part of their care? Is it protocolized in your patients there?
It's not necessarily protocolized, but yes, our providers do tend to choose that at maintenance IV fluids. We do see it on most of our patients, I would say, but it's not necessarily like a protocol that they're following.
Yeah, I think that I think that's pretty common in this patient population in particular.
Yeah.
So seeing as that was found, the maintenance IV fluids were found to be the most significant contributor to their chloride and fluid balance. Do you have any recommendations for mitigating the use of continuous IV fluids in this patient population, or do you think that's recommended based on the results of the study?
I do think that we should be mitigating it, especially in our patients with worsening renal function, and we see those levels go up of like sodium and chloride at that point. In my literature review, I also found that patients at baseline with AKI or CKD are at a higher risk of developing worse outcomes. So mitigating it in that sense, but also weighing the risk and benefits of prevention of vasospasm and other management as well, just kind of taking the patient in full picture and mitigating in that sense.
Yeah, absolutely. I think it's very tough to get neurosurgery providers to kind of buy into that because it's been such a deep-seated part of their care. So I know that some of our attendings, for example, our intensivists will try to encourage, just doing ins and outs checks multiple times per day and giving fluid boluses rather than continuous, because we tend to lose sight of how much fluid they're actually receiving.
Absolutely.
Yeah, great. Okay. I have at least one question or comment in the chat. So from Corinne, she says, I'm having a hard time attributing these outcomes with the chloride levels. As you mentioned, these patients receive more fluids and seem sicker. Should we change our fluid strategy based on the study? So sort of similar question to what I asked.
Yeah, I wouldn't necessarily change kind of just what we just discussed. But it does seem that as those patients were sicker, they had higher SOFA scores at baseline, and they might have needed that more fluid because they were sicker. So kind of both sides to it.
Yeah, absolutely. Okay, from Brooke Barlow, one of our authors of the study, she said, thank you for your presentation. Do you think there are any confounders with using serum creatinine as a marker for AKI in this population?
Confounding of using serum creatinine as a marker of AKI. We can also be using like urine output, whether over 6 hours, 12 hours, past 24 hours. There are other markers of worsening renal function for sure. So I wouldn't necessarily just rely on serum creatinine.
Mm-hmm. Absolutely.
And thank you for the study.
Okay, another question. So based on the study, are there any changes to your current institutional practice to fluid stewardship, choice of fluid with, and which patient subgroup will you monitor most closely?
Based on the study, I wouldn't necessarily change anything that we're already doing. I would kind of just be more cautious and wary. Those patients that are at baseline have a worse, poor renal function. I would pay more attention to those patients and watch for that fluid, chloride, sodium intake from sources that I don't really typically think of those IV boluses, antibiotics. Enteral nutrition is something that I hadn't really considered before as well. So kind of being more conscious of where it's all coming from for sure.
Yeah, I definitely agree with that. And I guess also the question of whether using normal saline versus more balanced fluids as well. That's certainly something that is making its way into neurocritical care in general. Another sub question, is the chloride content in enteral feeds and sodium chloride tablets significant enough to be attributed to AKI?
Enteral feeds, I mean, there's so many. I don't really have like a number off the top of my head, but with those sodium chloride tablets, I did kind of dive deep into how much sodium chloride is in there. So 1 gram has about 17 milliequivalents of sodium chloride. So if we're doing kind of what I typically see of like 2 grams 3 times a day, it's about like a little over 100 milliequivalents. So I don't think that alone will cause the AKI or could be attributed to that AKI. However, if we're doing that as well as fluids, as well as our IV boluses, maintenance fluids, antibiotics, it can all kind of add up. So just again, being cautious and wary of where it's all coming from.
Yeah, absolutely. Okay, I think that is it for everything that I have in the chat. So thank you so much, Sama. Great presentation.
Thank you
All
all.
right, so you can go ahead and stop sharing your slides, and then Andy can go ahead and share his. Oop, Andy, I think you're on mute.
And I think you were seeing my presenter view, maybe? Correct me if I'm wrong, 1 second.
Yep, we can see your slides now. Yeah.
Okay, not in presenter view, great. Well, hi there, everyone. My name's Andy. I'm a critical care resident here at Mayo Clinic in Rochester. And thank you for joining the second half of our Journal Club presentation today. We'll be looking at a study completed last year, published in Lancet, looking at intensive blood pressure control after endovascular thrombectomy for acute ischemic stroke. It was dubbed the Enchanted 2MT trial. So just starting with some background information, of course, we know mechanical thrombectomy is a common intervention that we utilize in our patients with large vessel occlusions and acute ischemic stroke, and that these patients are prone to have poor outcomes. Even when they do achieve a full level of reperfusion, 50% of these patients still have disability or death that persists after this, which suggests that we do have room for improvement. So why exactly is this occurring? When we look at the process of undergoing mechanical thrombectomy, we're essentially removing that big blockade in our vessel of the clot, and then we have this rapid influx of reperfusion and blood flow. And with that, in addition to the ischemia that was already present, we cause a disruption of our blood-brain barrier that can lead to what we call reperfusion injury in combination with other things such as reactive oxygen species and that shear stress, of course, that we're putting on our endothelium after removing that blockade in our vasculature. So this is thought to maybe contribute to hemorrhagic transformation that we see in these patients, which can contribute to maybe some of their poor outcomes. I think it is important for us to note that this risk, of course, can be amplified in patients that are getting thrombolytics prior to moving on to mechanical thrombectomy. So then how can we potentially help our patients and lower some of these events? The thought would be targeting a lower blood pressure after successful reperfusion can help put a brake on some of these processes as far as that rapid change in blood flow and shear stress and some of the other inflammatory mediators that might be ongoing. So where exactly then did we come up with this hypothesis that blood pressure and might be a valuable target? It really stems initially from some of our retrospective studies. A few that I want to mention is one that looked at the impact of just having a higher peak systolic blood pressure. And what they found in these patients after mechanical thrombectomy is that they were at an increased chance of hemorrhage at 48 hours, really for each incremental change in their systolic blood pressure. So really just that idea that a higher systolic blood pressure after thrombectomy can be harmful. And this also led to, of course, patient-oriented outcomes that showed an increased disability at day 90. And then additionally, another study that looked at a blood pressure target less than 160/90. What we saw in this study is that this target in patients that achieved this had a decreased likelihood of 3-month mortality with no change in their functional status. So that really kind of brings us to this idea that blood pressure might be a target. I think it is important to recognize up front. We also know that if we're causing too low of a blood pressure, we're of course going to be inducing some ischemia as well if we're not having a high enough blood pressure to perfuse our brain adequately. So what do our guidelines suggest in our current recommendations in 2019? It's pretty vague and just recommending that we maintain a blood pressure less than 180/105 for the first 24 hours after thrombectomy. And a large portion of this recommendation stems from a lot of our data from thrombolytic therapy and is extrapolated to this patient population as we're waiting for just higher levels of evidence to maybe come up with a different recommendation. So looking then at some of our larger randomized controlled trials for some of our background literature, starting first with the Enchanted trial. This was looking at patients with acute ischemic stroke that were eligible to receive thrombolysis. Patients were assigned to either an intensive systolic blood pressure of 130/140 versus the guideline recommended less than 180. There was 1,000 patients in each group roughly in this arm between the two different therapies, so a large trial. And what they were able to accomplish as far as their therapy in separating a blood pressure at 24 hours, they had a slightly reduced blood pressure in the intensive group versus the guideline therapy group. But we could see here that was roughly about a difference of 5 millimeters of mercury. So some might argue that might not be a wide enough difference for us to truly see an impact in practice. Although they didn't show a difference in functional status at day 90 when looking at the modified Rankin score. What they did see is there was less intracranial hemorrhage in the intensive group. So the hypothesis generating that for these patients, even a more aggressive blood pressure goal for patients receiving just thrombolytics might have better outcomes, even in comparison to our guideline recommendations. So then what kind of large size trials do we have for patients receiving mechanical thrombectomy? The blood BP target trial was more recently completed in 2021. And this looked at patients with acute ischemic stroke and large vessel occlusion after they had successful endovascular revascularization. And then in this trial, they compared intensive systolic blood pressure, which was defined as 130 to 148 millimeters of mercury versus the guideline recommended less than 100 millimeters of mercury to be achieved within a 1 hour time frame. I would note the sample size of this trial was much smaller than the previous Enchanto trial with 162 patients in each arm that underwent randomization. And then looking at their mean systolic blood pressure that they were able to achieve at 24 hours, we can see the intensive group was maintained at 128 millimeters of mercury, while the standard of care group was at 138 millimeters of mercury. So again, not that large of a blood pressure difference when we think about that difference at 10 in these groups. And they weren't able to achieve their primary outcome and didn't show any difference when looking at intraparenchymal hemorrhage at 24 to 36 hours in this trial. So in combination with the literature review thus far, the main thought there, and brings us to our study objective that we'll be discussing today, is that the optimal blood pressure goal after successful reperfusion still remains unknown. So really the goal of our study is to assess both the safety and efficacy of a more intensive blood pressure goal for our patients that do undergo successful reperfusion with endovascular thrombectomy. So moving in then to our methods of our trial, it was a multi-center open-label blinded endpoint study with a phase 3 randomized controlled design across 44 tertiary level centers in China. The authors did note that they plan to extend their study outside of China to Europe and North America, depending on their timeline of their trial. For inclusion criterion of our patients that were included, they looked at adults aged greater than 18 years or older that had to have a large vessel occlusion. This was included as interior or posterior circulation. And I would note in the previous BP target trial and some other studies, we've largely just looked at anterior circulation LVOs for these patients. So a little bit different in that aspect in this trial. Patients had to receive mechanical thrombectomy within 24 hours of their acute event, and then also had to have persistent elevations in their systolic blood pressure, which is defined as 2 measures above 140 millimeters of mercury. That rise in blood pressure lasted more than 10 minutes. That had to be within 3 hours of them having their successful reperfusion, which was defined as a thrombolysis and cerebral ischemia score of 2B through 3. I'll discuss that here in a second. And then lastly, there had to be an equipoise with the provider group in making this decision that they didn't feel strongly one way or the other of what would be the best therapy to receive. And then lastly, looking here at exclusion criterion, patients were unlikely, if it was deemed by the providing group that patients were unlikely to benefit from therapy, they were excluded. Also looking at illnesses that would interfere with study outcomes. This were things like advanced stroke disability at baseline, advanced cancer, and Parkinson's disease, and a few other disease states. There was a clear indication or contraindication for a certain blood pressure goal other than what would fit the study protocol. And then a few other considerations as far as conditions such as aortic isthmus and arterial venous shunts. And then lastly, patients that were lactating or had any kind of contraindication like a drug allergy to the therapies that were utilized or participating in a different center's trial. So moving on to our interventions and procedures. These patients had to achieve, after mechanical thrombectomy, a TICI score greater than 2B, which would be above 50% of that reperfusion. So in this case, 2B representing our group of 50 to 89% and 2C greater than 90%, or 3 would be our full 100% reperfusion. And in this, then the patients had that elevated blood pressure, as noted previously, that undergo randomization. And our two different arms here were then our intensive blood pressure goal of a systolic blood pressure less than 120 millimeters of mercury versus our non-intensive blood pressure goal. I would note that treatment was started for these patients if they received or had a systolic blood pressure greater than 150, but their actual target was to maintain the range of 140 to 180. So of course, I think that's important to note, as they weren't strictly just targeting a range of 140 to 180, they were actually starting therapy sooner than reaching that upper limit of 180. And then following this, the goal was to achieve their blood pressure within 1 hour and to maintain this for the next 72 hours. For what agents could be used for blood pressure lowering, it was largely local institution, supposed to be specific to their protocols, which really left it up to any agent could be used, whether it's IV bolus or continuous infusions. And then lastly, for systolic blood pressure, if it was less than 100 millimeters of mercury, the antihypertensives were to be stopped, and of course fluids and other resuscitative therapies were to be administered. The monitoring for blood pressure was pretty routine as far as what we'd expect as frequent assessments that would mirror what our guidelines recommend. Moving on then to our outcomes for our methodology. First, looking at our primary endpoint, this was defined as having assessment of functional recovery assessed by a shift in the modified Rankin score between groups at day 90. So the three different groups here would be those that had a favorable outcome, a score of 0 to 1, increasing disability from 2 to 5, and then those that experienced death at 6. And then secondary endpoints of interest, there's quite a few that they looked at. I think the important ones to call out would be looking at death or neurologic deterioration at day 7, which is defined as a shift in the NIHS stroke score, which we're familiar with, of course, but really what they did is they set 7 different groups of scorings in the range of 5. And if you had a shift and a worsening of more than 5, then you would be deemed to have that increased deterioration. And then they had multiple different definitions for intracerebral hemorrhage when they looked at these outcomes. Their primary one that they looked at being symptomatic ICH was defined as a hematoma that was greater than 30% of the infarcted tissue with obvious mass effects. And they also used the Heidelberg bleeding classification as part of that. But they did also look at imaging specific criterion and also asymptomatic ICH up to day 90. And then another important aspect that they looked at was a health-related quality survey. This was the EQ5D3L survey, which is broken down into just 5 different domains of functionality, things like mobility, self-care, their usual activity at baseline, pain, discomfort, and anxiety. And then also that was graded then on having no problem, moderate problem, or extreme problem for those 5 different domains. And then, of course, lastly, looking at serious adverse events as a secondary endpoint. Moving on then to our methodology from a statistical standpoint, when looking at their power and sample size, they expected enrolling 2,257 patients, assuming that 54% of the patients would have a poor outcome in the non-intensive blood pressure group. And that with assignment to the intensive treatment group, patients would have an absolute reduction of 6.48% as far as their shift in their functional outcomes. And that this would provide a 90% power to detect an odds ratio of 0.77 for those worst outcomes at day 90. For their efficacy analysis, they looked at an intention to treat that used ordinal logistic regression. This would be somewhat similar to our traditional logistic regression, except keeping in mind our modified Rankin scale would be on an ordinal score with treatment allocation as far as what they received as a fixed effect, sites as random effects, and time from onset of symptoms and baseline NIHS scores as fixed covariates. Additionally, they looked at adjusted analysis based on adding covariates that would be important as far as pre-stroke function, age, and sex. And they did have a plethora of other subgroup analyses that also included a per protocol analysis for those that just strictly followed their blood pressure regimen. I think also an important outcome was their blood pressure, which they looked at differences in systolic and diastolic blood pressures up to day 7. So moving in then to our enrollment, Just a few things I wanted to point out here is that of their patients that they screened, there was 821 patients that ended up being randomly assigned. And after a few other patients were excluded, this left 404 in the modified intention to treat analysis and 406 in the modified intention to treat, 404 patients in the intensive treatment and 406 patients in our less intensive treatment therapy for the modified intention to treat analysis. Unfortunately, from an enrollment standpoint, the trial was terminated early, of course, good for patient safety, but this was due to the Independent Safety and Monitoring Board taking a quick review at the results and deciding that the results could no longer support the trial going on. So then that left us with our smaller than anticipated. As a reminder, our sample size was expected to be 2,257 patients. Comparing then for our demographics, intensive versus non-intensive, no differences in these groups at baseline, but a few things I think was worth mentioning is the ethnicity is 100% of our patients in this population were Chinese. A lot of patients did have a modified Rankin scale of 0 at baseline, as the only patient that dysfunction were allowed in the study were 1 to 2, and we can see that made up a pretty small number of the trial of only about 18% of those patients. Patients had hypertension quite frequently at baseline, so over 50% of the cohort. Could be, of course, important when you think about how quickly we'd want to increase or decrease someone's blood pressure and where they might live as far as autoregulation at baseline. And a large majority of the causes of large vessel occlusions were related to intracranial atherosclerosis, and about a third of patients did receive alteplase. One of the last things to point out is their Tiki score of 3 suggests that a large majority of these patients excelled in their reperfusion rates and having 100% success on that, and about 84% in these two arms. So then moving on from our demographics to our primary outcomes and secondary outcomes of interest, looking at our intensive therapy versus non-intensive. Looking at our modified Rankin score at day 90, patients that received the intensive group actually had worse outcomes. So the reverse of what the initial study design and thought process would be. Hence why our study was terminated early. And then additionally, looking at our death or disability at day 90, what we saw then is that this was defined as a modified Rankin score of 3 to 6 on that scale, or of course having death. That more patients experienced this in the intensive group at 53% versus 39%. Although I would call out that there was no difference in death at day 90, so largely driven by the difference in the shift of the modified Rankin score. Then looking at death or neurologic deterioration at day 7, as a reminder, this was defined as that shift in the NIHSS score, and patients that received the intensive group had also worse outcomes. So maybe what is the glimmer of hope in this case, and that we have at least an impact in our symptomatic intracranial hemorrhage. And what we saw is there was no difference in between these two comparisons, looking at 6% in each. And they did have a plethora of other intracerebral hemorrhage definitions that they looked at that also showed no difference in those groups. When looking at the health-related quality of life assessment, patients reported overall worse scores in the intensive group. I would call out this was driven by worse mobility, self-care, and ability to complete usual activities. We also saw an increased number of patients that required tube feeding assistance at day 7 in the intensive arm. And then lastly, there's no differences in our serious adverse events. So let's take a little bit more time and break down our distribution of our modified Rankin scores on our scale here at day 90. And I guess the one thing I would call out here is when looking at the darker boxes, we can see as we're moving from left to right in our diagram here, patients are getting worse in their functionality, from 0 being, of course, that normal functionality to 6 being death. And really, we could just see a shift in the darker blue boxes from 4, 5, and 6 over, that more patients in the more intensive group had that, of course, trend in comparison to our less intensive therapy. And then let's also look at our blood pressure therapy to see were we at least achieving our designed goals for these patients of that less than 120 millimeters of mercury, and then our other group being in the 140 to 180 range. I think something I would call out here, then looking at our moving from on our y-axis, we have, of course, our mean systolic blood pressure, and then our x-axis here, time, with, of course, the changes from minutes, hours, and days. We can see in the first 15 minutes of starting therapy, there was quite a drastic decrease in patients in the more intensive group. So we rapidly caused a reduction after starting our therapies, which was really maintained then throughout the remainder of the phase of therapy through that 6-hour mark and 24-hour mark. So we were successful in decreasing their blood pressure, but I think this raises a little bit of a question of were we maybe too quick in dropping their blood pressure, as our goal was to get to our goal at the hour mark, but not necessarily within the first 15 minutes. So the mean systolic blood pressure difference at 24 hours was 18 millimeters of mercury between the two groups. So this was suggestive that, compared to a few of those other trials, we were able to at least accomplish this difference. And it's also meaningful to showcase that a difference of 18 can cause some significant changes in our patient outcomes that they experience. And when looking at the 24-hour mark, just to call out what did they actually achieve, in patients in the intensive group, they had a systolic blood pressure of 121 millimeters of mercury and 139 millimeters of mercury in the less intensive groups. So pretty close to our goal therapies there. A little bit more data just about the blood pressure goals and what agents were used. Not surprisingly, patients that received the intensive group had more systolic blood pressures, less than 100, being hypotensive. Some thought there that blood pressure variability and just, of course, that decrease to that degree could be contributing to maybe some of the negative outcomes that we saw. Looking at the usage of antihypertensives, more common with IV agents in the first 24 hours, and then also more common at day 2 through 7 with usage of any antihypertensive being either IV or oral. And looking at the IV agents that they did utilize, I think this is something that, of course, important to point out, was the usage of Rapidil was very common, and this is a therapy that we don't readily have available here in the United States. It would be an alpha antagonist. Of course, in our practice, we're more used to things like calcium channel blockers and beta blockers like labetalol potentially. So this is important when thinking about the external validity of the study. Looking at the author's conclusion, they thought, of course, that intensive blood pressure control less than 120 millimeters of mercury led to worse functional outcomes. So let's break this down a little bit and look at some critiques from this study. I think overall, it's worth mentioning a few strengths. They did, even though it was a non-blinded trial, what they did was at least mask the evaluation of the clinical outcomes. So of course, the clinicians taking care of the patient knew if they were in the intensive versus non-intensive group. It'd be quite hard to target a blood pressure, but the people actually evaluating their modified Rankin scores and some of the other outcomes were at least masked to that. The high rate of TK3 reperfusion gives us confidence that maybe then for our findings that our systolic blood pressure goal of 120 could be harmful in these groups. But at the same time, it does leave a little bit of room for considering what about their other TK scores that they were achieved this, since 80% or more of these patients fell into that group. I do think it's a strength that they were able to achieve a high degree of separation of systolic blood pressure. Just given that the previous trials, of course, a difference of 5 is unlikely to impact clinical outcomes. So maybe this gives us some kind of baseline of a difference that we can expect to see impact on clinical findings. And looking at weaknesses of the trial, it was terminated early. So of course, in our interpretation of the effect, we saw quite a dramatic effect, but in theory, potentially if more patients were enrolled, that effect size could have been reduced. Unlikely to have changed the outcome, but I think that's just a limitation we have to note. When looking at the systolic blood pressure goal of less than 120, can't say that this is a pretty aggressive goal, not commonly utilized in practice, and also could be potentially putting patients pretty close to them being on a hypotensive side of things as well. The increased percentage of patients that have atherosclerotic causes of their large vessel occlusions is a unique aspect, of course, of the patient population from an ethnicity standpoint, as the Chinese patient population can have a higher risk of these causes as opposed to some of our other stroke causes here in the United States. So of course, thinking about how the blood pressure goals might be different on the disease state causing our ischemic stroke. And then lastly, the common use of Rapidil, as mentioned previously, kind of hurts some of our external validity where we might not commonly be using this agent, as this agent itself problematic in comparison to others. So then wrapping up here with some relevance to practice, I would agree that targeting a systolic blood pressure less than 120 after thrombectomy is likely harmful for those that, of course, this study represents with LVO from atherosclerosis, sclerotic processes. The intensive blood pressure control group did not have any impact on symptomatic ICH as well. So of course, that would be what we think would be the upside of potentially using this to help impact patient outcomes. And then lastly, there's many unknowns remaining just regarding how to best customize our blood pressure for individual patients. And that's the exciting thing of where hopefully the future of this research is going, is that really we have then on the right side just a lot of other variables when we think about the cause of stroke, reperfusion status, baseline blood pressure, and certain agents that kind of further break down how we can best define someone's blood pressure goal. When looking at our relevance in practice, I do think this is an interesting survey that I just wanted to mention. When 131 sites were surveyed, 58 of them actually responded. And what we saw is that a lot of the time the decision is being made in a collaborative manner between our neuro ICU intensivists, but also with their neuro interventionalist colleagues to help determine this best goal. And with this, they're setting a target systolic blood pressure really dependent on reperfusion status most commonly in practice. And for those that achieved a high degree of reperfusion of 2B through 3, the most common target was 120 to 139 millimeters of mercury. And then lastly, nicardipine, a calcium channel blocker that we're used to utilizing here in North America, was of course the most commonly reported agent used. I think it's interesting that only 5% of centers reported targeting that aggressive systolic blood pressure goal. So wrapping up my take homes for this, the intensive blood pressure control after successful reperfusion is likely harmful. I think it's important for us to limit blood pressure variability just as much as thinking about which goal we want to target. This is likely just as an important of an aspect and warrants additional research. We saw in that first 15 minutes to an hour that drastic decrease in blood pressure in that intensive group. And then I think it's reasonable to target a systolic blood pressure of 140 to 160, although I think we really do need to take an individualized approach for these patients when thinking about all their factors. And lastly, the study is unlikely to change our local practice, but it confirms that utilizing that intensive target of less than 120 is likely inappropriate. I just wanted to put on your guys' radar a few future research trials that are being done, the best tune the optimal blood pressure trial that will be taking an additional look at this. So of course, there's interest in subsequent studies and looking at this further. But I'm happy to take this time now to answer any of your questions.
All right, thank you, Andy. Great presentation. So I again will be watching for any questions that come along in the chat. So in the meantime, I will start off with a question for you. Do you think that the results of the study will preclude further studies looking at this intensive blood pressure goal in this patient population of less than 120? And if not, if we were to do the study again, how would you kind of change how you would perform the study?
Yeah, that's a really good question. And looking at the equipoise of likely that goal of less than 120 millimeters of mercury, I think this trial would suggest of the patient population that would most likely benefit, given the number of TK3 patients, that'd be the most to gain group. So given the findings, if I were reviewing this from an IRB standpoint, I definitely wouldn't think it would warrant additional studies looking at 120. To your point though, of what would maybe be then the knowledge we can gain from this as far as designing a subsequent trial, I think they did do a successful job of achieving their blood pressure goals early on, but just maybe that degree of what they're hoping to achieve and then shooting, I think would be more reasonable for that intensive group to be more closer to that less than 140 group, less than 130. I think can make an argument. So one of the studies I mentioned, the best two at least has 3 groups, which of course sample sizes splitting up might limit some of our ability to take away from the effects that we're seeing, but they have a group of 160 to 180, 140 to 159, and then less than 140. So I think landing on that less than 140 would likely have been where I would have started with the intensive therapy group.
Yeah, really interesting. Another question that I have for you. Do you think that their decision to not really standardize how to manage blood pressure, meaning that each local site could decide how to or what agents to use, et cetera, for blood pressure lowering? I know you commented on like the high use of Urapidol, which is not an agent that we commonly see in the United States, but this a little bit reminded me of the INTERACT-2 study, which is a study on intensive blood pressure lowering in patients with intracerebral hemorrhage, where basically the study sites could use any agent that they wanted, including oral agents. And basically what they found was really wide obviously fluctuations in blood pressure, but also like inability to achieve the goal. We obviously achieved the goal in the study, but do you think that that matters? Like, would you suggest future studies maybe use only like a continuous infusion agent versus bolus agent, or do you think it's just reflective of like current practice in the world?
Yeah, if it was up to me, of course, recognizing multiple centers that might limit some of that availability of certain agents. But if it was up to me, I would try to design a protocol that utilized continuous infusions, whether it's nicardipine or clofidipine, and those options at least. I think that's at our center would be typically what we would utilize as a first line as needed or blood pressure control agent. I think the usage of as needed boluses could just get problematic with the possibility to cause those changes in blood pressure variability. So I almost view that, of course, when we're looking for a rescue agent with a patient coming in to the ED where we do need that quick drop to maybe help them get to a blood pressure where they need to get a thrombolytic. I think of those PRNs from bolus standpoint being helpful, but in this kind of a slower game that we're trying to play after thrombectomy, I think our continuous infusions really should be coming into play more. And then it would be helpful then to at least have those protocols for those institutions to follow when you're doing a multi-center project. And I think the usage of continuous infusions would be advantageous in this patient population.
Mhm. Yeah, or at least like take that question out of how you're
Yes, definitely.
evaluating the results. Yeah, absolutely. Okay, so a question from the chat. Can you comment on the choice of antihypertensives used? How would you design the study differently if you had to pick an agent? So we kind of answered that question just now, but you can kind of see if there's anything else you want to add to that. And are there any agents that you would avoid?
Yeah, good question. That, of course, familiar with Rapidil and their usage, of course, nitroglycerin made up over 11% or something like that. And we don't commonly utilize that either in our neuro ICU for our practice. So I don't necessarily know if that, warrants enough attention to these are agents we should avoid. I don't necessarily think we can conclude that from this study alone. But of course, in our center and our practice and for designing future studies, when available, I do think that agents such as beta blockers like labetalol would be more of our traditional as needed, as Rapidil was given as more of a bolus as needed for multiple doses, then started as a continuous infusion. Labetalol was used in 0% of patients in the trial, actually 1%, sorry, in the intensive group, whereas calcium channel blockers such as nicardipine were used quite frequently in this, but and compared to the best blood pressure trial that I mentioned earlier, that was actually most of what they use as a study designed in Europe. So of course, it's a different location for that.
Absolutely. All right. Next question in the chat. Given such wide variation in systolic blood pressure noted in this trial, does your institution provide a lower limit SBP goal for nurses to prevent hypotensive episodes?
Yeah, typically in our PRN orders, I'll most commonly see, depending on, of course, our TQ reperfusion that we achieve, it's really going to be a range of 140 to 160 most commonly is what I see in our order set that's kind of default that comes through. Of course, there might be some additional discussion that occurs between the providing group, but that at least gives our nursing team some parameters to help follow to make sure we're not dropping them below 120, or they just aren't paying attention to maybe where a drip's at and we're getting an accumulative effect of our nicardipine or something like that.
Yeah, it's interesting. Does your institution protocolize that blood pressure range for like your post-thrombectomy patients, or do they decide on a case-by-case basis?
It sounds like it's a little bit more on a case-by-case basis. As far as our order set, there's not a specific blood pressure goal that gets noted depending on their TQ reperfusion. So a little bit more that I think that aligns with that survey, that it's still somewhat of an individualized decision after that patient returns.
Yeah, absolutely. It's pretty similar in places where I practice as well, even more so these days that it's kind of not defaulted and up to the team to kind of make those decisions.
Definitely.
Okay. All right. Well, I don't see any further questions in the chat. We're now at 3:01. So that concludes our journal club for today. Thanks to you and Andy and Sama for your presentations. And you have both posted pearls and then questions in Twitter. So please feel free to follow along with hashtag NCSPharmJC. And we will see you on Twitter. All right. Thanks to everybody for your attendance today, and great job. Thank you.